Stop for a second. Whatever you were doing, put it down. Because what I'm about to tell you in the next few minutes is something most people only learn after they're already in the emergency room, and by then, the window to act has closed. I'm Dr. Nathan Wells. I'm a board-certified internal medicine physician. I've spent more than 20 years treating patients over 60, in clinic, in hospital consults, and at the bedside after fractures that nobody saw coming. I've watched people lose their independence, their mobility, and in the worst cases, their lives. Not because they ignored their health, but because nobody told them what to watch for before things broke down. That's why I make these videos. Here's the number I want you to sit with. According to the CDC, 1 in 3 adults over 65 who fractures a hip will be dead within 12 months. Not from the fracture, from the cascade of complications that follows it. Pneumonia, blood clots, the irreversible physical decline that sets in when a body that was already aging suddenly can't move. 1 in 3. And most of those people had no idea their bones were already failing years before they hit the floor. After 65, bone doesn't just get generally weaker. It changes structure, in specific locations, in predictable ways. And 3 zones of your skeleton are where that change concentrates first. I'm going to walk you through all 3, but the first one is the one that stops most of my patients cold when I explain it, because it means a fracture can happen without a fall, without a stumble, without any dramatic event, and you might not even know it occurred for months. If this is the kind of information you want more of, leave a comment below and tell me what health topic you'd like me to cover next. I read everyone. Now, let's get into this. Before I go further, a quick word I always say to my patients when they sit across from me. What I share here is education. It's meant to sharpen your awareness and give you better questions to bring to your own doctor, who knows your full history, your medications, your bone density numbers if you've had them checked. I don't diagnose through a screen. Your physician does that with your complete picture in front of them. The first danger zone is the hip, specifically the femoral neck, the narrow column of bone that connects the ball of your hip joint to the long shaft of your femur. Picture a lollipop stick. Narrow, load-bearing, and when it fractures, it doesn't just crack like a dry branch. In older bone, it shatters in a way that often can't be repaired with a simple pin. It requires replacement surgery. And the data from the CDC is grim. Roughly 300,000 Americans aged 65 and older are hospitalized for hip fractures every year. Within 12 months of a hip fracture, approximately 20 to 30% of those patients die, not from the fracture itself, but from complications like pneumonia, blood clots, and the rapid physical decline that follows prolonged immobility. Let me put that another way. A hip fracture at 70 carries roughly the same 1-year mortality risk as many early-stage cancers. People take cancer seriously. Hip fracture prevention gets a pamphlet in the waiting room. Why does the femoral neck fail specifically? Because after 65, the internal scaffolding of bone, the trabecular network, which looks under a microscope like a dense honeycomb, starts losing struts faster than the body can replace them. The femoral neck has always had a relatively thin outer shell, so when the inner scaffolding weakens, it has almost no backup system. Add to that the fact that many people over 65 walk with a subtle shift in gait, slightly wider steps, a compensating lean, and the mechanical load on the femoral neck changes in a way that concentrates stress exactly where the bone is weakest. Your skeleton is an engineer, a tired, aging engineer making daily calculations to keep you upright, and the hip is where the math eventually gets hard. One of my patients, a retired contractor named Frank, 68, came in after his wife dragged him to see me. He'd been having groin pain for about 4 months, dull, intermittent, easy to ignore after a career of ignoring aches. His wife had noticed he was favoring his right leg without realizing it. When we got imaging done, he had significant femoral neck thinning and early stress changes that hadn't yet reached fracture. We caught it. He started a structured fall prevention program, his medications were adjusted, and he got his bone density properly evaluated for the first time in his life. Frank's story went well, but only because his wife paid attention to something he'd trained himself to dismiss. The groin pain is the tell most people miss. Hip fracture risk doesn't announce itself with hip pain. It announces itself with groin pain, and sometimes with a vague ache in the upper thigh that people assume is a pulled muscle. If you're over 65 and you've had unexplained groin discomfort for more than a few weeks, that warrants a conversation with your doctor. Not a Google search, a conversation. The second danger zone is one that surprises almost everyone I tell it to: the spine. Specifically, the vertebral bodies, the blocky, load-bearing segments stacked on top of each other that form your spinal column. Vertebral compression fractures are the most common fragility fracture in older adults, and according to the National Osteoporosis Foundation, approximately 2/3 of them go undiagnosed because the patient, and sometimes even their doctor, attributes the pain to arthritis, muscle strain, or just getting older. That's a staggering number: 2 out of 3 vertebral fractures flying under the radar. Here's why it happens. When a hip fractures, you fall. Something dramatic occurs. A vertebral compression fracture can happen while you're sitting down, coughing hard, or rolling over in bed. The vertebra, under load it can no longer support, collapses on itself like a soggy cardboard box. The pain is real but often manageable with over-the-counter medication, so people wait it out. Weeks pass. The fracture heals in a compressed position, and the vertebra is now permanently shorter. One compressed vertebra changes your posture. 2 or 3, stacked over several years without diagnosis, produce the forward curve in the upper back, what's clinically called kyphosis, what most people call a stooped posture, and once that curve is established, it creates a mechanical problem that feeds itself. The forward lean shifts your center of gravity forward, which increases fall risk, which increases the chance of additional fractures. Margaret, the woman I opened with, had a compression fracture in her thoracic spine. When her surgeon showed her the imaging, she could see 2 older fractures that had healed silently, fractures she'd attributed to a bad stretch of back pain she had 3 years prior. She hadn't fallen either time. She'd just hurt. The research in the Journal of Bone and Mineral Research has documented something called the fracture cascade, the significantly elevated risk of a subsequent vertebral fracture once a first one has occurred. After one vertebral compression fracture, your risk of another within the following year increases by approximately 5-fold. The spine doesn't fracture in isolation, it fractures in sequence. What should you pay attention to? A sudden onset of mid-back or upper back pain that didn't follow any obvious injury. Pain that worsens when you stand or walk, but eases when you lie down. A visible increase in the forward rounding of your upper back that wasn't there 2 years ago. Any acute height loss, losing an inch or more over a short period. These are not normal aging. They are signals that deserve imaging, not patience. If you found this video helpful so far, I'd genuinely appreciate you sharing it with someone in your family, a sibling, a parent, a friend who just turned 65. This is exactly the kind of information most people only get after a fracture happens, not before. That's the part I want to change. The third danger zone catches people completely off guard, and that's the wrist, specifically the distal radius, the end of the radius bone that forms the bottom of your wrist joint. A wrist fracture might sound like the least serious of the 3. It's not a hip. It's not a spine. People get wrist fractures in their 30s falling off bikes. But here's what changes after 65. A wrist fracture in a person under 60 is usually a trauma fracture, significant force, typically healthy bone that simply absorbed more than it could handle. A wrist fracture in a person over 65 is almost always a fragility fracture, a fall from standing height, or even less, onto an outstretched hand that shouldn't have broken under those circumstances. And according to research published in Osteoporosis International, a distal radius fracture in a woman over 65 is one of the strongest predictors of future hip and vertebral fractures. It's the skeleton sending a warning flare that most people ignore because the wrist heals, they do physical therapy, and life goes on. Think of it like the check engine light on an old car. The wrist is the warning, the engine is the hip. I had a patient, a woman named Carol, 73, retired school teacher, sharp as anyone I've ever met, who fractured her wrist catching herself after slipping on a wet kitchen floor. The fracture was straightforward, healed well. What her orthopedic surgeon at the time did not do was refer her for a bone density scan. What her primary care doctor at the time did not do was treat the wrist fracture as a red flag. 2 years later, Carol fell again, this time a slight misstep coming down her front stairs, and fractured her hip. When she finally got the bone density scan, her T-score was -2.9, severely osteoporotic. For 2 years, that information had been sitting in her skeleton, unread. I want to be precise here because this matters. If you have fractured your wrist after a minor fall or a low-energy event after age 60, and you have never had a bone density scan, a DEXA scan, that conversation needs to happen with your doctor at your next appointment. Not when you remember, not next year, the next appointment. Why does the distal radius fail so specifically? Because the end of the radius is composed predominantly of trabecular bone, that honeycomb scaffolding, with a very thin shell of cortical bone surrounding it. When bone density drops, trabecular bone is the first to thin. The end of the radius becomes, essentially, a shell with very little inside it. Your natural reflex when you fall is to throw your hand out to protect yourself, and what you're doing is driving all of your falling body weight directly into the thinnest, most trabecular dense part of your arm. It's not a design flaw, it's just physics meeting aging. What can actually be done? I want to spend time here because awareness without action is just anxiety, and that's not what I'm in the business of creating. The first thing, and I will not apologize for repeating this, is knowing your bone density number. A DEXA scan takes about 20 minutes, involves no needles, and gives your doctor a T-score that quantifies exactly where your bone density sits relative to a healthy young adult baseline. The National Osteoporosis Foundation recommends DEXA screening for all women 65 and older and all men 70 and older, and earlier if you have risk factors, long-term steroid use, smoking history, low body weight, early menopause, a parent who had a hip fracture. If you haven't had this scan and you're in that age range, ask for it by name at your next appointment. Your doctor can order it. Many insurance plans cover it. Medication is a real option when the T-score warrants it. Bisphosphonates, drugs like alendronate, which most people know as Fosamax, work by slowing the rate at which your body breaks down old bone, giving the formation side of the equation a chance to keep pace. They're not perfect, they're not for everyone, and the decision requires a physician who knows your full kidney function, your history of esophageal issues, and several other factors. But they exist. They have decades of data behind them, and a surprising number of people who qualify for them never get them because the conversation never happens. Calcium and vitamin D matter, but the details are more important than the headline. The body can only absorb a limited amount of calcium from a single dose, roughly 500 milligrams at a time, so splitting intake across the day is more effective than a single large supplement. Vitamin D is what enables calcium absorption in the gut. Without adequate D levels, much of the calcium you consume simply passes through. Your doctor can check your vitamin D level with a standard blood test and give you a specific target range rather than a generic recommendation. Ask for the number. Resistance training, actual progressive resistance, weights or resistance bands, not just walking, directly stimulates bone formation. The mechanical load from resistance training signals osteoblasts, the cells that build bone, to lay down new material. A study published in the Journal of Bone and Mineral Research found that progressive resistance training programs in older adults produced measurable increases in bone density at the hip and spine over 12 months. Walking is good for your heart and your joints. It is not sufficient on its own for bone. The distinction matters. Balance work is the other half of the equation. Most hip fractures start with a fall. Most falls are preventable with the right intervention. The AHA recommends balance training, things like single-leg stands, heel-to-toe walking, Tai Chi, as part of a comprehensive fall prevention strategy. A single-leg stand, held for 10 seconds on each side, practiced daily, produces measurable improvement in balance within weeks. It's not glamorous. It also doesn't require a gym membership. Margaret has done well. After her compression fracture, she finally got her DEXA scan, something she'd been putting off for 3 years, and started treatment. She told me at her last appointment that the strangest part of the whole experience was realizing her bones had been failing silently for years while she felt essentially fine. She'd attributed her slowly worsening posture to just how things go. She'd written off the back pain episodes. Her body had been sending messages she hadn't been given the vocabulary to read. That's what I want to leave you with. Your bones are not silent because they're healthy. They're silent because bone doesn't have nerve endings in the sense that skin does. It doesn't feel thin the way a muscle feels weak. It just fails when it fails, which means the information has to come from somewhere else, from a DEXA scan, from paying attention to pain patterns that don't fit a simple explanation, from understanding that a wrist fracture after a minor fall is not bad luck. It's data. The three zones, your hip, your spine, your wrist, are where that data gets written first, before anything more serious happens. You now know what to look for. You know what questions to bring to your doctor. You know the difference between the warning and the crash. Take care of your bones before they ask you to. I'm Dr. Nathan Wells. Stay aware, stay proactive, and take care of yourself. I'll see you in the next one.